In this lecture, I will present the pelvic viscera. This is the third section of this lecture series. My name is Carlos Andres Suarez-Quian. I am the author and narrator of this lecture. As before, I list the objectives of this lecture, but will not read them now. They will form the slide headings as I proceed with the lecture. Let's begin. Previously, I showed you this slide to define the area of the true pelvis. The true pelvis is contained below the arcuate line of the bony pelvis and above the pelvic floor. The space of the abdominal cavity is contiguous with that of the pelvis. However, the parietal peritoneum physically sequesters the content of the abdomen from that of the pelvis. As you will see shortly, it is possible to approach the pelvic viscera and not disturb the peritoneal cavity. But before discussing the peritoneum, let's define the pelvic viscera in both sexes. On the left, a dissection of a female hemipelvis is illustrated, whereas on the right, a drawing of the vagina, the uterus, and its adnexa are included. The sacrum and pubic symphysis are labeled for orientation. The drawing was made as if you were seeing the uterus from the back, that is, from the sacrum. Adnexa is a clinical term used to describe the pelvic structures adjacent to the uterus. Let's label these structures. Going from posterior to anterior, we find the rectum. Next, the uterus. Unlike the uterus in the cadaver, however, the uterus is generally located flex anteriorly in a position called anteverted. But as you have seen in the actual dissection, the uterus can also be flexed posteriorly, in which case it is called a retroverted uterus. There is nothing wrong with this, but the physician checks the location of the uterus when women become pregnant, as we will see shortly. And continuing with our survey of the pelvic viscera, I now indicate the cervix of the uterus. And the vagina. Vagina means sheath in Latin. Anterior to the vagina is the urinary bladder. The urethra is the tube that takes the urine from the bladder to the outside. That's when one voids. Do not confuse it with the ureter. Lateral to the uterus, the ovary and fallopian tubes are apparent. We will have more to say about the organs later. However, I have prepared a brief table describing the minimal information that you should know for each organ. Clearly, you will gain much more information for each organ in the physiology and histology components of your courses. Let's do the same exercise for the male and name the pelvic viscera. The bisected cadaver pelvis is on the left, with the sacrum and pubic symphysis serving as orientation landmarks. On the right is the drawing of the pelvic viscera. Let's start by labeling the urinary bladder. Inferior to the bladder is the prostate. Posterior to the prostate are the seminal vesicles, and these are joined by the ductus deferens, entering the abdominal cavity from the deep inguinal ring. The ureters enter the urinary bladder just above the seminal vesicles. The male urethra begins in the prostate and travels within the corpus spongiosum of the penis. We will discuss the penis when we discuss the perineum. Finally, here's the rectum, just posterior to the prostate. And again, here's a short table describing the minimum function for each male pelvic viscera that you should know. Now that we have listed the pelvic viscera, let's describe their position in the subperitoneal region of the pelvis, the location for the true pelvic organs. All pelvic viscera organs, in both the male and the female, reside inferior to the parietal peritoneum that we discuss in detail when we studied the abdominal cavity. And it is important to be able to trace this parietal peritoneum as it drapes over the pelvic organs, both in the female and in the male, to understand clinical scenarios. First, let's trace a parietal peritoneum in the female pelvis, shown here in a drawing made from a sagittal section. The parietal peritoneum starts in the posterior abdominal wall to pass just superior to the symphysis. It covers the superior surface of the urinary bladder, then passes from the superior surface of the urinary bladder to the uterus, where it forms the vesicle uterine pouch. From here, the peritoneum covers the fundus and body of the uterus and contacts the wall of the posterior part of the vaginal fornix. The peritoneum again turns on itself to form the rectal uterine pouch, or as it is known clinically, the pouch of Douglas. The peritoneum covers the anterior surface and sides of the rectum to form the sigmoid mesocolon, beginning at the level of the third sacral vertebra. Let's explore now in more detail the area of the parietal peritoneum as it envelops the uterus and its adnexa by looking at the drawing in the cadaveric dissection from above. The relevant pelvic viscera structures are now labeled in the cadaver. The function of this parietal peritoneum just discussed is to provide support for the uterus and its adnexa. Within the area of the uterus, this parietal peritoneum is given the specific name of the broad ligament. And, perhaps to make it more complicated than it needs to be, the different components of the broad ligament are granted different names. For example, the part that drapes over the fallopian tube is known as the mesosalpinx. Again, understand that the peritoneum is completely covering the fallopian tube. The name mesosalpinx comes from the Greek. Meso refers to mesentery and salpinx is a tube. Indeed, the long slender horns of ancient Greeks were known as salpinx. The mesentery that suspends the ovary is the mesovarium, and the portion of the broad ligament inferior to the ovary is the mesometrium. Another way to get an idea of how these ligaments run in a two-dimensional plane is to look at the draping of the uterus by the broad ligament from the side, as is now shown in the left-hand image. Also, note the important relationship between the uterine artery and the ureter. The ureter is inferior to the artery, or, as we say in the business, water runs under the bridge. There are two other ligaments of the uterus present in the drawing that also offer support. One you know, the round ligament of the uterus, and the other is the uterosacral ligament. To round out the labeling in the drawing, we also have the ureter and the uterine artery. Finally, with respect to providing support to the uterus, realize that there are other ligaments as well, and these have significant implications during a hysterectomy. Now shown on the left is a drawing of the pelvic organs in an axial section. If the broad ligament is removed, it exposes the important transverse cervical ligament, also known as a cardinal ligament. The cardinal ligament helps anchor the cervix to the midline. In a hysterectomy, this ligament needs to be cut, and herein is the principal surgical complication associated with hysterectomies. the ureter can be inadvertently cut. The reason for this is that the uterine artery resides on top of the cardinal ligament and the ureter is just below it. Even though gynecologists know this relationship well, sometimes it is just difficult to identify the ureter and avoid injuring it. The area is just jam-packed with structures, especially if there's inflammation associated with the need to perform the hysterectomy. Indeed, the running joke among urologists, the surgeons that would repair an injured ureter, is that the only natural predators of the ureter are gynecologists. Before leaving the slide, let's mention a couple important points about the ovary and the fallopian tubes. The ovary has two ligaments, one at either pole. Suspending the ovary from the pelvic brim is a band of peritoneum that contains the ovarian vessels, the artery, vein, and the lymph, the suspensory ligament. Hence, unlike in the male, the gonadal vessel does not exit the pelvis but does cross the pelvic brim. Perhaps you should look at these important relationships in your textbook. The second ligament is the ligament of the ovary, between the ovary and the uterus. It is nothing more than a band of connective tissue. Let's now look at the fallopian tube. The infundibulum with its finger-like fimbriae, the ampulla, and the isthmus. It is via the infundibulum and the fimbriae that the peritoneal cavity is connected to the outside world and a potential source for peritonitis. In addition, fertilization generally occurs within the ampulla, and if the embryo does not migrate back into the uterus, an ectopic pregnancy can ensue with catastrophic results. Having looked at the parietal peritoneum in the female, let's now turn to the male. We can do the same exercise of tracing the parietal peritoneum in the male pelvis. We again notice that the peritoneum passes from the anterior abdominal wall superior to the pelvis, covers the superior surface of the urinary bladder, then travels inferiorly along the posterior surface of the urinary bladder and approximates the seminal vesicles. From there, the peritoneum turns on itself to generate the rectovesical pouch, gains contact to the anterior surface and sides of the rectum to give rise to the sigmoid mesocolon beginning at the level of the third sacral vertebrae. Do not think for a moment that what we have gone through is simply an academic exercise in memorizing the path taken by the parietal peritoneum as it drapes over the pelvic organs. Here, I show a hemipelvic bisection of the male and female pelvises. I now indicate the extent of the parietal peritoneum as it drapes over the pelvic organs in both sexes. Now, focus on the fact that the parietal peritoneum physically separates the abdominal content from the pelvic organs. It makes possible the surgical approach of a pelvic organ without compromising the peritoneal cavity. And why is this important? Remember the term peritonitis, inflammation of the peritoneum secondary to infection of any of its organs. One of the great advances of modern medicine was recognizing that it's possible to minimize peritonitis by avoiding entering the peritoneal cavity. By recognizing that the parietal peritoneum sequesters one compartment from the other, allows clinicians to strategize surgical approaches where they can enter the pelvic organs, yet minimize exposure to the abdominal content. As to what these surgical approaches might be, think hysterectomy, ovarian cancer surgery, prostatectomy, tubal ligations, etc. The next objective to present in this lecture is to describe which pelvic organs can be palpated in a digital exam. In the female, here are the classic examples: the digital exam of the vagina, the bimanual palpation of the uterine adnexa, for example, the ovaries, and the rectovaginal examination to confirm the uterus is retroverted. It would not surprise me if in the future the use of ultrasound technology makes these invasive palpation exams obsolete. In the male, the prostate and seminal vesicles can be palpated via digital rectal exam. Previously, this exam was recommended for all males beginning at age 40, but annual exams are no longer the norm. They basically have no value, except when a man is symptomatic. Our next objective is to describe the blood supply of the pelvic organs, and this is rather straightforward. The abdominal aorta bifurcates into two common iliac arteries that then divide into an external and an internal iliac artery. This is clearly shown in both the dissection image on the left and the drawing on the right. The traditional description is that the internal iliac artery will then subdivide into an anterior and a posterior division, although this is less clear in many dissections as shown on the left. Arteries that are relatively expressed in a constant fashion include the umbilical, from which several arteries to the urinary bladder arise, the superior vesicle arteries. The obturator artery may also be present, and this exits into the thigh, although there are significant variations with this artery. As expected and mentioned previously, the uterus receives a major vessel, the uterine artery, as well as vessels to the rectum, the middle rectal, and an artery that will exit the pelvis and travel to the perineum, the internal pudendal artery. Vessels also leave the internal iliac artery and feed the gluteal muscles. We will discuss these in detail when we study that region of the body. The last two arteries of the internal iliac artery include the lateral sacral and the iliolumbar. All these arteries are of importance when the surgeons enter these regions. What is clear, however, for any anatomy course is that if you know the arteries, you also know the veins and also the lymphatic drainage. Yes, there are more details regarding the lymphatic drainage that you will learn if you become a urologist or gynecological surgeon, but for now, understand that if you know the arteries, you also know the veins and the lymphatic drainage. Arteries that are of particular clinical relevance include the uterine artery. As a reminder, the ureter flows under the uterine artery, and it is at risk for injury during a hysterectomy when the uterine artery is ligated. Having finished describing the female blood supply, what is relevant about the male blood supply in the pelvis? Basically, each organ receives its own blood supply, as a female does, and these details become important when you are performing surgery in this region. Short of that, realize that all organs receive their own blood supply. There is an area of the pelvis, however, that is peculiar in its blood supply, yet readily easy to explain in terms of its development. The upper part of the rectum receives its blood supply from the superior rectal artery, a branch of the inferior mesenteric artery. Hence, its venous return will be by way of the superior rectal veins back to the portal circulation. The lower portions of the rectum, however, receive their blood supply by way of the middle and inferior rectal arteries, branches from the internal iliac arteries. Hence, their venous return will occur via the corresponding veins, ultimately back to the inferior vena cava. These are caval veins. But there is another feature about this vascular supply of the rectum that bears mentioning. blockage of the superior rectal vein occurs during portal hypertension, that is, when the liver is deceased. If this blockage occurs, the venous return from the superior rectal veins is impaired and these veins become engorged, leading to hemorrhoids that are painless. And the reason that these hemorrhoids are painless is that they are occurring above the pectinate line in the area derived from the endoderm. Pain receptors located here are not somatic receptors, and the pain sensory sensation felt here is vastly different than if you were to cut your skin. Below the pectinate line, a person can also develop hemorrhoids, that is, veins can also be backed up and engorged, but this backup is not due to liver disease. And in contrast to the hemorrhoids above the pectinate line, these hemorrhoids are painful. This is because the skin of the anus is derived from ectoderm, that is, from cells that do express somatic type receptors. Interestingly, these painful hemorrhoids can be treated with over-the-counter drugs, whereas the painless hemorrhoids may ultimately require the individual to undergo a liver transplant. The final topic of discussion in this lecture becomes that of the autonomic nerves of the pelvis, nerves that are both sympathetic and parasympathetic in nature. Previously, I showed a dissection of the sacral plexus similar to the dissection image shown on the left. I now add the autonomic innervation in the drawing on the right. Recall and understand that sympathetic innervation arises from the thoracolumbar regions of the spinal cord. Hence, as indicated in this slide, the sympathetic innervation to the pelvis originates from these regions by way of sympathetic nerves and will end up at the superior hypogastric plexus. The superior hypogastric plexus is both visceral motor and visceral afferent. Hence, information is traveling in both directions at this level. Any sensation from the viscera will be traveling to the CNS by way of these fibers as well. The parasympathetic innervation to the pelvis emerges from sacral nerves S2, S3, and S4 and joins with the hypogastric nerve to form the inferior hypogastric plexus. Hence, the hypogastric nerve conducts both parasympathetic and sympathetic innervation between the superior and inferior hypogastric plexuses. The parasympathetic nerves also travel to the superior hypogastric plexus by way of the hypogastric nerve. Bottom line, it is the fibers from the inferior hypogastric plexuses, one on each side, that innervate the pelvic viscera. For example, if you've heard of nerve-sparing surgery of the prostate, it is the plexus that emerges from the inferior hypogastric plexus and courses close to the prostate, which is referred to in this procedure. Injury to this plexus may lead to impotence in a man. For the same reason, women may experience sexual dysfunction if similar nerves are damaged during pelvic surgery, for example, during a total hysterectomy. In very general terms, I've listed the functions of the sympathetic and parasympathetic nerves in the slide. The sympathetic nerves from the plexus innervate blood vessels, cause contraction of smooth muscles in the internal urethral sphincter in men. Women do not have an internal sphincter, and in the internal anal sphincters in both men and women, and cause smooth muscle contraction in the reproductive tract associated with ejaculation. Parasympathetic fibers are generally vasodilatory, stimulate bladder contraction, stimulate erection, and modulate the enteric nervous system of the colon distal to the left colic flexure. This now concludes the third section of this lecture series on the pelvis.